So this is an example for what a resectable pancreas cancer looks like. If you look at the T, that's the tumor. It's a hypovascular lesion. There's a stent in place there. And in this graphic, you'll see that the superior mesenteric vessels are clear of the tumor. There's a fat plane, so there's a good probability if this individual went directly to the operating room that a complete removal would be able to be done. Thinking about staging of localized pancreas adenocarcinoma, we have the AJCC classification, but in greater utility is the breaking up of pancreas adenocarcinoma into the spectrum of resectable disease and locally advanced and unresectable, which is characterized by T4 tumors with arterial involvement, where it isn't possible to do a complete or zero oncologic resection. And then that group of tumors in the middle, which are about 15% of people with pancreas adenocarcinoma presentation, called borderline resectable disease, where there's venous involvement but not encasement, and to a lesser extent, limited arterial involvement. And the designation of borderline resectable means that an individual technically could go to the operating room tomorrow, but there's a high probability of having a margin positive resection. So we don't recommend that, and increasingly this group of patients is recommended neoadjuvant therapy. So it's important here to emphasize the role of high volume treatment centers with improved diagnostic management and complex multidisciplinary decision making. We know that surgical outcomes are optimized when patients are treated in centers where there's a high level of expertise in looking after patients with pancreas adenocarcinoma. And that includes not only the surgical care, but the postoperative care, management of complications, and the optimal use of systemic therapy, radiation where it's indicated, and integration of targeted opportunities where they exist for individuals. So looking at resectable and borderline disease, for patients who have operable pancreas adenocarcinoma, the traditional approach is upfront surgery followed by adjuvant systemic therapy. If there's a suspicion of more advanced disease, so for example, if an individual has a very elevated CA19-9 level or a distal site, so a body or tail location, then often it will be recommended to do a laparoscopy to rule out subradiologic disease before committing to a complete resection. An area of evolution in terms of approach is to recommend neoadjuvant therapy for patients with resectable pancreas adenocarcinoma. We don't have randomized data to indicate that this is a superior approach, but there's been a move in that direction by surgeons and medical oncologists. For patients with resectable cancer, we have some studies that will mature out over the next year or so that will further inform the data to support this approach in this population. And we talked about for resectable disease, upfront systemic therapy, often including chemoradiation and subsequently surgical resection is the paradigm that's undertaken.